Hello and welcome to our special session on artificial urinary incontinence. Today we are joined by three distinguished experts in the field of urology who have made significant contribution to the advancement of urological prosthetics and male sexual health. First, we have Professor Koenraad van Rentergem from Belgium. Prof. van Rentergem is a highly trained and experienced urologist, specializing in general urology, andrology, and urological prosthetic surgery. He serves as a professor at Hasselt University and a consultant urologist at university hospitals in Leuven. Prof. van Rentergem is renowned for his research in prostate pathologies and erectile dysfunction, and he brings a wealth of knowledge and expertise to our discussion today. Welcome, Professor.
Thank you.
Next, joining us from the UK is Mr. Roland Rees. Mr. Rees is a leading consultant urologist based in Hampshire and London, specializing in male infertility, erectile dysfunction, and male incontinence surgery. He's one of the UK's few full-time dedicated specialists in andrology and genital urethral surgery. Mr. Rees is also actively involved in clinical research, making him a valuable voice in our conversation today. And lastly, we're honored to have Dr. Tobias Potek from Germany. Dr. Potek is an esteemed urologist focusing on reconstructive urology and male sexual health. He is known for his proficiency in penile implants and particularly artificial urinary sphincter procedures. Dr. Potek has significantly advanced surgical techniques in this field, and his expertise will greatly enrich our discussion. Thank you all for joining us today.
Thank you.
To start our discussion, let's address some of the key questions that patients often have about the artificial urinary sphincter. The first one being, how do I know if I'm a candidate for the artificial urinary sphincter? Professor van Rentergem, could you explain how a patient might determine if they are suitable candidate for an artificial urinary sphincter?
Well, to start with a technical answer, so the artificial urinary sphincter is a treatment for patients with refractory stress incontinence. To make it a little bit more clear to the audience, you have more or less two types of incontinence. One is urge incontinence, which is incontinence due to an overactivity of the bladder, which means that you can lose urine because you're too late to get to the toilet, to the restroom. We are talking about the other type of incontinence, which is stress incontinence, which does not have to do anything with stress situations. Stress means pressure. When the pressure in the abdomen, in the belly of the patient is high, and the sphincter, so the muscle, the pelvic floor, is not strong enough urine. In a normal clinical situation, this is that you lose urine, for example, when you're doing an exercise, when you're lifting a weight, when you're cuffing, when you're sneezing. And these patients, we see them most frequently after prosthetic surgery, mainly surgery for prostate cancer, but it can happen also in surgical treatment for benign prostatic enlargement. So severe incontinence, not responding to pelvic floor exercise, mainly after prosthetic surgery, mainly in prostate cancer.
Thank you, Professor van Rentergem. On to the second most common question. How does the artificial urinary sphincter work? And this is addressed to you, Mr. Rees. If you could walk us through the mechanism of the artificial urinary sphincter and how it helps in managing the urinary incontinence.
Well, thank you. Yes. So it's a simple device, really. It's a mechanical device that essentially mimics the actions of our own urethral sphincter, i.e. it essentially compresses or squeezes the urethra to prevent urinary leakage. And when, as Professor van Rentergem mentioned, our own sphincters are deficient, then an artificial sphincter can do pretty much the same thing. Essentially, it's a plastic cuff that sits around the urethra, so it's not inside the waterworks. It's it sits around the urethra, compressing it, and it's got an amount of fluid or saline, salty water essentially, in this so-called cuff that sits around the urethra, pressing on it. And then the second component is a little pump, and the pump sits usually in men, it will sit in the skin of underneath the skin of the scrotum, and that can be felt underneath the skin. And when the patient or the gentleman presses on the pump, then the pump essentially empties the cuff of saline, and the pressure comes off the urethra, allowing the bladder to empty. And the fluid is actually pushed into another component, the third component, which is a little pressure regulating balloon, which contains that fluid for a short while. And then gradually, once the patient's passed urine, the pressure regulating balloon pushes the fluid back into the cuff, and it compresses the urethra again, regaining continence. So it's a very simple mechanical device. As I say, it's been around for 50 years almost. And it depends on those simple mechanical principles of pressure.
Thank you, Mr. Rees. On to the third most common question, and this one is to you, Dr. Potek. Once the patient has done their research, they would ask, can I choose the type of AUS that I'll be receiving? Dr. Potek, are there different types of AUS available? And can patients choose the type that they receive based on their specific needs?
Well, that's an interesting question. And I think it's a little bit different from where the patient lives. So in Germany, we have a law that says you can choose your doctor. Everybody is free to choose his doctor, but you do not know exactly what the doctor does. These times we have 3 companies who are building and selling artificial urinary sphincters. That's Boston Scientific. We have the American Medical System sphincter, the old one, which is 50 years old now. Then we have Sapphire from Switzerland and France, and we have Rigicon from US and Turkey. And all these 3 companies make the thing a little bit different. And what I always say in my clinic is that it's very good to have all these 3 things, except we have also male slings for some patients who are living in very special conditions. For 10 to 15% of the incontinent patients, male slings are enough. But if you have taken the choice by recommendation of your doctor, you should get an artificial urinary sphincter. You should ask him, which of the 3 sphincters do you implant? What do you think is the best for me? And then he will say okay, I'm using for several years the products of company number, so and so. And then you can ask him, why don't you use the other ones? And do you know the advantages and disadvantages? And then he must say something. He must answer you. If he cannot answer, he doesn't know all the 3 things, and he doesn't know the advantages and disadvantages for them. We do that in my clinic. We differentiate very intense. We check if the patient has a constant pressure in his abdomen or if he has a changing pressure in his abdomen, because there are different systems available for these 2 conditions. And we ask, is it possible to implant a balloon into the abdomen of the patient? Did he have a lot of surgery before? Maybe then it would not be so very keen to implant something into the abdomen. Then it may be better to have a system which is only in the perineum, and so on and so on. So there are a lot of questions which can be answered by an expert, and the patient is not the expert. The patient is the expert for himself, and he has to choose his doctor by his feeling. Yeah, if he trusts the doctor, and if the doctor can say, I know all these 3 products, and I also know male slings, and for you, I recommend to take this or that, and you have the feeling as a patient, I can believe him, then give yourself into his hands.
Thank you, Dr. Potek. This was greatly informative, especially that it's a topic that's mainly discussed. Nowadays, the patients are doing their own research, Dr. Google. So thank you for answering it accurately. They should all go to their specialist and take it from there. I'll circle back now to Professor Van Rentergem with a common question, especially that the patient will be getting an implant, an artificial body in their own body. The question goes, will the AUS be noticeable to other people? Prof. Van Rentergem, one common concern is whether the AUS will be noticeable. Can you shed some light on this?
Well, let me give first a very short, clear answer. The answer is no. Of course, I would like to explain a little bit why the answer is no. I think that this question might originate a little bit in penile implant prosthesis, because this is a comparable device. Also, as Mr. Rees explained, a 3-piece device in many patients. And this is maybe a little bit more noticeable in a patient than an artificial urinary sphincter. As Mr. Rees explained how an artificial urinary sphincter works, well, the first element of the device is the cuff, which is around the urethra, which is really inside the body of the patient. So this is not noticeable, not at all. The second part is the pressure regulating balloon, which is located in the lower abdomen. So once again, this is not visible, not noticeable. Of course, by definition, the pump, which is meant to work with the device, this should be noticeable, but to be more specific, it's not visible. When you look on the outside, you will not see there is a device inside the patient. This is more or less the same with a penile implant. By the way, from the outside, you cannot really see anything. Of course, you need to feel, you need to have a tactile feedback, and you should be able to localize the pump, because this is the part of the device that you need to handle and that you need to use so that the device works. So the only thing that is possible to be felt if you feel and you manipulate the scrotum is the pump. The pump is very small. It's about 2 centimeters long, and it's less than 1 centimeter in width. So it's a very small thing, but you can, of course, you can feel it, because this is the way you have to manipulate and let it function.
Thank you, Prof. Van Rentergem, for easing the doubt on the patients that the concealability is great and it will not be noticeable. And I'll continue with Mr. Rees onto a post-operative question that goes as follows. What can I expect, Mr. Rees, during the recovery from the surgery? And what should patient expect during this period following the surgery?
Okay, yeah. So the operation itself tends to be done under a general anesthetic. Takes an hour or so, an hour and a half sometimes, and can be done as a day case operation, or sometimes a one-night stay. I think those would be the typical scenarios. And it's usual to have a catheter in, usually for a short period during the surgery and afterwards, and that's soon removed either the same day or the next day. And then the key things for patients to appreciate is that it is not immediately effective. In other words, once the artificial sphincter has been inserted, there has to be a period where I describe as bedding in, where it's left deactivated or switched off, essentially, so that the body can get used to it effectively, and it is not activated straight away. So I explain to patients that they will still be incontinent for a period of time, still need their pads or their Convenes or whatever they're using for anything up to 6 weeks after the surgery. So that's part of the deal. Now, in terms of physical recovery, then it's I make the analogy of hernia surgery with patients sometimes. That's the level of surgery, in that for the first week, I tell them just to potter around at home, don't do too much, certainly don't do too much too soon. A lot of these patients are, as been mentioned, post-prostatectomy. They may be in their 70s or their 80s, and healing takes time. And therefore, for the first 1 or 2 weeks, activity levels should be fairly low, really. Then after 2 weeks, they can start to do walks and get out and about and build up their physical activity a little bit more. And then in terms of heavy lifting, not that everybody wants to do heavy lifting, but certainly heavy lifting, well, I would say wait the full 6 weeks. My typical post-operative care is to either meet the patient or call the patient at around 2 weeks to check how things are going, check the wound, and then I bring them back at around 6 weeks following the surgery, and that's the day where the device is turned on or activated, and therefore that's the moment of truth where we get to find out, hopefully, the patient is dry and continent, and thankfully the vast majority are.
Well, that's a comforting postoperative period to look forward to, especially when accompanied by an expert. Thank you, Mr. Rees. Dr. Potek, I'll circle back to you now that you answered the question on choosing the type of sphincter. And once this choice is made, the question would be, how would I prepare for the surgery? So Dr. Potek, could you provide some guidelines on how patients should prepare for the days leading up to their surgery?
Yes, it's a little bit like in sports. The better prepared you go in, with the better results you come out. And very important for implantology, we are implanting a foreign body into the body of the patients, is that the body does not reject it. The reason for rejection in the most cases is infection. So the contamination of the surface of the implant by bacterial germs and biological films, let's say like this. And the problem is the patients who have a bad opportunity to fight against that have a higher chance to get a rejection and an infection of the devices. So what do you have to do? There are some factors which are very important. Number one is smoking. Smoking makes the rate of infections more than 10 times higher than a non-smoker. That's a whole lot. So I know there are some implanters who say, before you stop smoking, I will not implant you a foreign body. I will not implant you a device. So that's a very hard decision. I don't do that so hard, but my recommendation is you have to try to stop smoking for the rest of your life because it brings nothing. There is no advantage by smoking. There's nothing. It only makes you sick. But especially for this time now, you must try to go down to 0 cigarettes every day. That's the first thing. The second is diabetes. A lot of people have in the, let's say, third of their lives, they get a diabetes. They are obese, they have a high weight, and sometimes a diabetes occurs, and you can't blow the diabetes away. What you can do is to sink your weight, reduce your weight by dietetic measurements. So we say Mediterranean food, olive oil, omega-3 fatty acids, and all these things to try to get down with the weight and to strengthen your muscular power. This is very important. And the second is, not every patient can reduce his diabetes by dietary measurements. Then you have to talk to your doctor, to your diabetologist, and tell him, I want to have an implant, and please help me to reduce my diabetes as high as possible or as low as possible. There is one laboratory finding, it's the HbA1c. It should be under 7 in the German terminology. In different countries, the level is different, but you can ask your doctor, what is the best level for having surgery with my diabetes? So this must be in a close context with the diabetologist and the GP. Third thing is hypertension. Hypertension deteriorates the microcirculation, and it's very important to have a good microcirculation around the implant because we need the healing there. Yeah, there will be scars. That's normal, but in a scar, the fighting potency against germs is low, and the better the microcirculation is, the better is the healing. And one very deciding factor is the blood pressure. So you can do it also together with the GP or in the internal doctor. Take medicine if necessary to get the level of the tension of the blood pressure down as possible. These are the 3 things: smoking, diabetes, hypertension.
Thank you, Dr. Potik, for highlighting the patient screening and the importance of looking into their medical history before proceeding, because all of you gentlemen have dealt with patients who show up, have done the research, and straightforwardly ask you for the sphincter. So back to you, Professor Van Rentergem. You've showed us how the patient might determine if they're suitable for artificial urinary sphincter. And you mentioned the level of incontinence, whether it's mild, severe, or light. And definitely there are other choices. So the question to you is, what should I discuss with my doctor before getting this artificial urinary sphincter?
First, let me explain what I tell all my patients if they come for either incontinence, either erectile dysfunction, and they are looking to have an implant. Well, first of all, this is a non-life-threatening condition. So far, nobody died of erectile dysfunction. Nobody died because of incontinence. So you should make your patient clear that, is this condition bothering enough to have a surgical intervention? This is the first question I think you should discuss with your patient. And it's striking to see how patients can look very different towards these questions. There are patients that are very happy with a suprapubic catheter with a convene, a condom catheter with a diaper, so they should be willing to undergo surgery. It's not a big operation, as Mr. Rees explained, but anyway, it's an operation with a certain risk, and as Dr. Potik told us, there are some risks, for example, infection, rejection. So this is the first thing. The second is what you mentioned, Yves. How severe is the incontinence? And I think Dr. Potik mentioned already the possibility of a male sling. So you have the artificial urinary sphincter. On the other hand, you have also a male sling, which is a little bit comparable to the sling operations we do in female patients when they have stress urinary incontinence. Of course, because of the anatomy of the male patient, it's more complicated to have a male sling inserted in a patient compared to a sling in a female patient. The big difference is what you mentioned, the amount of urine loss. And another thing we didn't really talk about, but Tobias, you mentioned the different types of devices, Zephyr and Rigicon and Boston Scientific. In our country, only Boston Scientific is reimbursed. So this might also be a local condition that might be important in which device you can offer the patient. So anyway, if you talk about the male sling is in Belgium not reimbursed, which means that a patient has to pay a couple of €1,000 out of his own pocket. However, many patients today have private insurance on top of the national healthcare system. So many patients do have coverage of the expenses of an implant or a sling. But this might also be something that you have to take into account. Is the patient insured or not? And then let's talk about the amount of urine loss. I'm quite conservative, which means that one thing is there are urologists doing slings in patients with urine loss over 400 cc's per day. I think that is far too much. If I operate on a patient and he has to pay out of his own pocket 2,000 to 3,000 euros and he ends up with the same level of incontinence, he will be very unhappy. So this is one of the reasons that I'm quite conservative and I limit the amount of urine loss. I prefer that they lose less than 100 cc's per day, which is, if you look at 100 cc, it's also a lot of urine. If you just pour a glass of water with 100 cc's on your pants, you will be really wet. Another thing that is important, of course, an artificial urinary sphincter, and this is one of the questions that will come up later on. You might have mechanical problems that might need reintervention. However, if you look on the long-term results of artificial urinary sphincter regarding continence, and you compare this to a male sling, it's striking to see, and this has been published in European Urology, that the efficacy on the long term between an artificial urinary sphincter and a male sling is more or less the same. So the recurrence of incontinence in both patient groups is after a couple of years the same. So you have to discuss with your patient all these factors involving, but to answer your question short and briefly, to resume, I think the amount of urine is the most important question that you have to ask your patient. How much do you lose? And I prefer them to weigh. They have to weigh the urine loss per day, which is not that difficult.
Thank you, Professor Van Rentegem. I'll circle back to Mr. Rees, who addressed the kind of physical activities that the patient can still engage in or not, especially in the recovery period. As we know, not all patients lead the same lifestyle. And as you gentlemen established, this is not a life-threatening surgery. It's what we call in our field an elective surgery. So if we have to categorize different patients by different lifestyle categories, Mr. Rees, how does having an AUS affect the patient's ability to engage in their different levels of physical activities postoperatively?
Well, thank you. Yeah, I mean, when patients come to see me to talk about this problem, then one of the things I say initially is that the aim of this is to restore their lifestyle back to what it was like before they had the problem, or typically before they had their prostate removed. And very often, we don't see people straight away. There may be a delay in presentation for various reasons. And also, they will have lowered their expectations. So they might say to you, oh, before I had my radical prostatectomy, I used to play golf and I used to go running and sailing and this and that and the other. And now, because of the leakage, I don't really do this. And they've reset their expectations. And therefore, one of the key factors when you're treating this condition, I think, particularly with sphincters and slings, is that we aim together with the patient to try and restore their lifestyle to the expectations they had beforehand. And I often therefore ask them, what did you do? What would you like to be doing? And then they will tell me. They might be playing golf, they might be swimming, walking up mountains, goodness knows what. And therefore, I mean, the short answer to this question is yes, that we should be aiming with these treatments, particularly with the artificial sphincter, I think, to be able to restore men to all the physical activities that they would expect to do and did before they developed the incontinence. And that includes running, swimming, hiking, sexual intercourse, golf, flying, sailing, whatever. There's a few exceptions that I will tell them about. Now, that's particularly anything to do with the saddle. Now, the artificial sphincter cuffs that we've talked about sit in the perineum, in the midline of the perineum. And in most people, there is very little tissue between the skin of the perineum and the urethra, and hence the cuff. So they have to be a little bit careful, because that's a fluid-filled plastic device that can, go pop if you were to probably be rough with it. And therefore, I say to them that if they're keen cyclists, that they may want to consider getting a cutout seat where there's a gap in the middle, so there's no pressure on the perineum. And similarly with other saddle sports. And the other thing, of course, is when they're sitting down, particularly on hard surfaces, is not to jump, violently onto hard chairs and whatever, but to lower themselves gently, because there is that cuff in the perineum that we want to try and get the most number of years out of, and therefore not treat it too unkindly. So the short answer is yes, that after this, the whole point of this surgery really is to get back to your original level of physical activities.
Well, thank you, Mr. Rees. And it's often about setting the expectations right. So thank you for answering this in detail. Now we'll move to an often underlooked question for every recipient of a foreign body, especially if they're senior enough to be undergoing different medical exams, like a magnetic resonance imaging or an MRI. The question is now to you, Dr. Potek. Are there any restrictions or considerations for patients with an AUS when it comes to undergoing MRI scans, for example?
The answer is very simple. No, there are no problems. Technically spoken, it's so that all these devices are MRI conditioned, is the technical term. And there have been a lot of tests for that with MRI scanners of 1.5 and 3.0 Tesla. That's what we have in routine examinations for different diseases and so on, because a patient with an incontinence might have some other diseases too. And we have also patients which have neurological diseases who need a penile implant, for example, with the encephalitis disseminata. And these patients need repeated MRIs of their spine, or spine injury patients also. But we can say, if you have an implant from silicone with some small metal pieces inside, most of them are not magnetic, you have no problem to get examined by MRI scanners.
Thank you, Dr. Potek. Last but not least, a topic that Professor Van Rentergem touched based on. How long does an AUS last? So it's about the lifespan of the device. And what is the likelihood of needing a revision? And what's the importance of the warranty on the device and the expertise of the surgeon and his team around when it comes to this topic?
It's a very interesting, very good question, very important question. Again, I would like to extend a bit to penile implant also. If you discuss an implant, either penile, either artificial urinary sphincter, one of the issues you have to discuss with your patient is the question, are you willing to undergo revision surgery? Especially in artificial urinary sphincter, this is more important because reinterventions in artificial urinary sphincter are more frequently than in penile implant. There are two reasons for this. One reason is that the mechanism of the artificial urinary sphincter is much more delicate compared to the penile implant because the pump, the valve, the amount of fluid, it's all smaller, it's more delicate. Another thing is very important. One of the dangers of, or the risks of an artificial urinary sphincter, and I come back to the question that Mr. Rees touched, how does it work? Well, it works like our own sphincter, which means that in normal condition, the cuff is tight and is compressing the urethra, which means that 99.9% of the day, the urethra is compressed mechanically by this cuff, which will cause, and I come back now to what Dr. Potek told, because if you have a bad circulation, for example, in the hypertension patients, because of this continuous pressure on the urethra, you might end up with atrophy. And of course, atrophy is a disaster because if you have an atrophy, you have a risk of erosion. If you have an erosion, you have an infection and you have to take everything out. And if you want to come back, it will not be very easy normally. So you should explain that this risk exists. And this is one of the arguments where I like to err on the safe side. I think that you should always aim to have the pressure and the size of the cuff not too small. I would like also to mention now that, you know, as Dr. Potek told us, we have Zephyr, we have Rigicon, we have Boston Scientific. Rigicon has a very good invention, which is the Conti Reflex device, where you have some kind of mechanism to regulate the pressure in the cuff to prevent a continuous high pressure around the urethra. To answer your question more specifically, Yves, we do know that after 5 years, around 30% of the patients with an artificial urinary sphincter will need a revision because of any problem. If you look at the 10-year survival, we have 50%, 1 out of 2 patients that will need a reoperation. If you look on the longer term, 15 years, there will only be 15% of the devices that are still functional. So the revision rate is considerable, and this is something that is very important to explain to your patient. However, the revision surgery should not always be very difficult. So if there is any mechanical problem, I saw a patient today where I have scheduled him now for a downsizing of the cuff. The reason for this is that after a certain time, you can have some atrophy of the urethra, making that the closing pressure is not sufficient enough to prevent incontinence. So the bottom line of this question is, yes, reinterventions are possible and are not rare.
Thank you, Professor Van Rentergem. And thank you, gentlemen, for your precious time, your insightful answers. You have all explained to us that there's no one size fits all. Then we have to tailor the solution based on the patient's medical history, their lifestyle, the adequacy of the solution to them. So the topic is still open. And before we conclude, is there anything else that the three of you would like to add about the AUS or any advice for the patients considering this option? I'll leave you the floor open and your microphone open.
Well, I have maybe one small remark regarding the question of MRI, where the answer of Dr. Potek was absolutely 100% correct. I would like to add that MRI is, in my opinion, a very valuable exam, technical exam we can do if we want to have more information on what might be going wrong with the device. This is even more the case in penile implants, but MRI is the technical exam number 1, I think, to have a diagnostic workup if you want to know what is going wrong with an implant, either penile, either artificial urinary sphincter. And so indeed, there is no influence at all, or there's no danger having an MRI with these devices in the patient. That's one thing I would like to stress maybe.
Thank you, Prof. Mr. Rees, those were common questions, open questions. Is there any other common question that your patients address when meeting with you?
When we're counseling patients for this procedure, I think, like I'm sure all of us, I do believe strongly in realistic management of expectations, and therefore, patients will be more likely to be prepared and happy with the outcome, essentially. But one of the things I mentioned is that in health, for instance, when we sneeze, our pelvic floors will clench, so the pressure on the bladder goes up hugely, and then the pressure on the urethra goes up transiently. And I think Prof. Van Rontgen mentioned that in terms of the Conti reflex concept. But in general, the Conti reflex accepted, but in the other implants, I would manage my expectations to say that if there are very high pressure rises, such as sneezing or coughing with a full bladder and this sort of thing, they may expect a small leak, because of course the artificial device does not necessarily, the conventional ones don't contract or don't tighten when there's a rise in pressure. They just stay the same. They're not connected to the nervous system, and therefore most of the outcome measures in most of the studies for this type of operation would include 1 pad per day as a successful outcome. And I therefore say to them that, to be realistic, that, just to expect one, even as a very small insurance pad a day, that to expect complete perfection and drip dry is sometimes unrealistic. And therefore, particularly for men who are only using 1 pad to start with, I would say, well, you need to consider strongly whether you have anything done, because we may not render you pad free, and that one small pad may be a realistic expectation. And I think that's something I mentioned to all of my patients, and they get that, and they're also very happy, because most of them are using multiple pads a day, changing them during the day, changing them, and able to go out for long periods. Whereas for most people, one small pad a day is not a problem.
If I may just add two small remarks. One, I think I fully agree, Roland. I would say err on the safe side. Second, under promise and over deliver.
Yeah.
So you should indeed tell them that they might not be completely 100% continent, and therefore maybe under promise a bit.
There is one recommendation which comes from my heart, I tell you. If you have an implant, maybe it's an artificial urinary sphincter or a penile prosthesis, that's not the problem. If you have an implant, it's a part of your body, and it's a part of your life, of your former life, and you have to take care for that. And not only you have to take care for that, but also other doctors who are treating you. So we have some patients who had prostate cancer, which had bladder cancer too. This is possible. It's a not so small amount, about 10 to 12% have both cancers, and they need aftercare. And the aftercare of bladder cancer is the cystoscopy. Put a camera into the bladder, look around, look if a recurrence coming or something like this. And if you have to do such an examination, if you have to do an endoscopy in a patient who has an artificial urinary sphincter, you must know how to deactivate it. If a doctor, maybe urologist or somebody else, puts his cystoscope through the closed sphincter, he will destroy it. And he must know that there is an artificial urinary sphincter. So it's very important for the patient to say, hey, my doctor, I know you have to make a cystoscopy with me, but do you know, here is my passport. I have an artificial urinary sphincter now since 1 year or 2 years. And do you know how to deactivate it? And if he does not know, give him the small passport, the card you get from the hospital who implanted it, and then the doctor can inform himself. The internet is full of information, and all the companies who provide medical devices, they have special information also for the doctors, how to open the device and how to deactivate it during the examination and how to activate it afterwards, so the patient will again go home with dry pants. This is very important. And I've seen all the time I do that. A lot of stories and a lot of problems because somebody didn't say hello in the right moment, and then it happens, and then the catastrophe is there. And I don't want to do that. I don't want to see that in future so often like I did it in my past.
You're touching a very, very painful point, Tobias. It's very painful. And I scare my patients. I tell them, you cannot allow a doctor to do a cystoscopy or a catheter inside without dealing with the sphincter. And my patients are really very scared. Even then, and this is what I would like to add, even then, I have every year one patient who, I have seen one today. Patient is so scared, he says, no, you cannot put in a catheter. I have an artificial urinary sphincter. You need to open it, deactivate, whatever. And always you will find a doctor who believes he's God. No problem. I put in a catheter, I do a cystoscopy. Don't worry, my dear patient. It will not harm. Of course it harms. And it's a disaster for those patients. Erosion, explantation, waiting for a long period, having a reoperation, and most of the times with a lesser outcome than the first implant. So this is very important, Tobias, what you told us. Indeed, if they need endoscopic handling, whatever, they need to take care of the sphincter. But unfortunately, many times, I think in the UK, in Germany, Belgium, everywhere, you always have colleagues not caring about this patient's problem and ruining and harming the patient and creating a real disaster. It's sad.
Yeah, I think I would agree. We've all got, stories. I think it must be quite frightening to think that every surgeon that does this work will have stories like this, and what it all amounts to. I can think of 3 or 4 patients certainly where that's happened, usually in a non-specialist hospital, maybe accident emergency, junior staff, non-specialist staff who are either not listening or ignoring or pretending or thinking they know best, all of the above, and then disaster happens, and it's awful for those people because their quality of life suddenly goes from being excellent to being dreadful again, and it's a much more difficult problem, as you said, to sort it out. Once there's a hole in the urethra, then gosh, it's a totally different ball game, and you couldn't ever recover that position, really, can you? So yeah, it is a really frightening prospect, and I like your idea of really alarming the patients and making them hypersensitive to this, because it does happen even in 2024 in Europe and in the Western world. It still happens, and there are still doctors who have never heard of an artificial sphincter.
Well, indeed, that's the case. And in the age of the abundance of information, what we're trying to do here is to bridge the needs of the patients looking for answers, but also other healthcare professionals with the right experts, and position you gentlemen as the experts that people have to go to, so they end up with a successful surgery and indeed a better lifestyle. I thank our esteemed panel for your precious time and sharing your experience on this important topic. This session has provided valuable insights in the world of artificial urinary sphincters and their role in improving your patients' lives. Thanks for the audience for tuning in. Until the next time, on behalf of Rigicon, stay informed and take care.